Hi, I'm Rui Pereira da Costa, organizer of this World Online Congress of Endodontics, and the next topic had to be in this Endo Masters. Endodontic regeneration procedures represent a true hot topic and a promise for a more conservative approach on teeth with immature roots. And it's an honor to have my friend Antonis Chaniotis from Greece lecturing on this topic. Antonis completed a postgraduate program in endodontics at the University of Athens Dental School. For the last 10 years, he was a clinical instructor affiliated with the undergraduate and postgraduate programs in endodontics at the University of Athens, and in 2012 he was awarded the title of Clinical Fellow Teacher at the University of Warwick Dentistry in the UK. Antonis is a great believer in online education, as he serves as an expert lecturer for various websites of online dental education. He is passionate about video documentation in microscope-enhanced endodontics and believes in the educational power of video presentations. I'm sure you'll enjoy.
Okay, so hello everybody, dear respected colleagues and friends. It is a great privilege and honor for me to welcome you all at the first online endodontic event called the Endo Masters 2015. I'm Antonis Chaniotis from Greece, and before I start, I would like to specially thank Rui Pereira da Costa and everybody behind the scenes for making this amazing event possible. My topic for this meeting would be about regenerative endodontic procedures. And when discussing regenerative endodontic procedures, I agree with Professor Simon and colleagues that we have to differentiate between two entities. One is dentin pulp complex regeneration, which could also be called dentin odontoblast complex regeneration and relates to the preservation of the pulp vitality and pulp capping. And the second one is the dental pulp regeneration that relates to the regeneration of a vital tissue into an empty but infected root canal space. As far as dentin pulp complex regeneration concerns, the aim of such treatment would be to keep the pulp vital and maintain its homeostatic functions, avoiding pulpectomy or extraction of the tooth. The problem with vital pulp therapy is the diagnosis of the pulp tissue condition. Is the pulp tissue inflammation irreversible, or in some locations the inflammation may be reversible and in other locations irreversible, and how all these things can be assessed clinically in a child. In one hand, clinical methods for establishing pulpal status like vitality testing or measuring pulpal blood flow were found insufficient and of little value in this systematic review of the literature. On the other hand, in a very recent histological study, after the application of defined criteria for clinical and histologic classification of pulp conditions, a good agreement was found between clinical and histological diagnosis of pulp tissue inflammation. Whenever clinical reversibility was assessed, it matched with histologic reversibility, and whenever clinical irreversibility was assessed, it matched most of the times with histologic irreversibility. So, in a case like Comninos developing first mandibular molar with deep carious lesion, what will be our treatment approach here? Our first concern here would be to avoid pulp exposure. Stepwise caries excavation may prevent pulp exposure in cases like Comninos case and offer a good long-term prognosis. However, what will be the suggested treatment if the pulp gets exposed? Root canal treatment or a regenerative approach? The objective of regenerative procedures here will be to regenerate dentin odontoblast complex at the site of the exposure. In permanent developing molar teeth like Comninos case, partial pulpotomy can offer a favorable long-term prognosis. After caries removal, the pulp tissue was exposed, and with the diamond ball ultrasonic tip under continuous 2% fluorescein irrigation, the exposed pulp tissue was removed. Bleeding was controlled with pressure and MTA was placed. Over the MTA, glass ionomer and composite resin restoration. At the 1 year follow-up, dentin wall thickening and length increase was evident. Vitality testing was within normal limits. 3 years later, complete root development after partial pulpotomy in Komnenos case was evident. The response to thermal vitality testing was again positive, suggesting that a vital functioning pulp tissue exists here. So, pulp dentin odontoblast complex regeneration was considered quite successful in the case of Komnenos. But what happens in cases of developing permanent teeth with more extensive pulp tissue inflammation, like Noura's case that was referred to my practice back in 2010? MTA partial pulpotomy here seems inadequate to deal with the extensive pulp tissue destruction, and although total pulpectomy or extraction were alternative treatment approaches, full pulpotomy sometimes could prevent extraction in cases like this. Full pulpotomy, full MTA pulpotomy in cases of immature permanent teeth. Symptomatic immature pulp tissue inflammation in a mandibular molar in a 9-year-old girl is consistent with clinical irreversibility. The objective of dental pulp complex regeneration here will be to preserve the radicular pulp vital in order to achieve apexogenesis. Pulp exposure in Noura's case was over 5 mm in diameter with signs of prolonged bleeding. In cases like this, full MTA pulpotomy can be attempted with the sole objective the completion of the formation of the roots. 2.5 years follow-up evaluation revealed successful apexogenesis of the immature root. In fully developed molar teeth, however, with a deep carious lesion like Nicola's case, what would be your suggested treatment approach? Of course, every single one of you can perform a root canal treatment in a case like this. The roots are fully developed. But what if we could predictably preserve the pulp vitality even in cases of fully developed permanent teeth like Nicola's case here? 16 years old, asymptomatic, fully developed roots in this first mandibular molar. Partial pulpotomy can be applied again here even in fully formed and erupted permanent teeth like Nicola's case. Same disinfection protocol with continuous chlorhexidine irrigation and a ball ultrasonic diamond tip that is inserted in 1 to 3 millimeters inside the pulp tissue, pressure hemostasis, and another calcium silicate cement that was used here. Here it was used biodentin as a pulp capping material to cover the traumatized and infected pulp tissue. You can see here the pulp exposure, pressure hemostasis with a sterile cotton pellet embedded with chlorhexidine, and biodentin was placed over the pulp tissue exposure. The first shot of biodentin is mixed with the blood, the second shot will be thicker, and the third shot would stay there, and you can wait for 12 minutes for the material to set. After setting of the material, you can proceed without the need of protection of biodentin with the final restoration, composite resin restoration of the cavity over there. 2 years later, comparative radiographic evaluation suggests that the regeneration of the odontoblasts complex was achieved successfully at the site of the initial pulp exposure. Amazing regenerative potential of young pulp. And if you have some doubts about the dentine pulp complex regeneration in Nicola's case being that evident in the radiograph, in the follow-up radiograph, in the next case of partial pulpotomy, the regeneration will be evident even for the most strict reviewer. Diamandis case here, deep carious lesion with pulp exposure. Diamandis was referred for root canal treatment of his first mandibular molar back in 2010. And although root canal treatment was a very predictable treatment approach, I selected again here MTA partial pulpotomy for this 10-year-old boy with exactly the same clinical techniques. Caries removal with diamond-coated ultrasonic tip under continuous chlorhexidine irrigation. The ultrasonic tip was inserted 2 mm inside the pulp tissue. Bleeding was controlled with pressure hemostasis with a sterile cotton pellet embedded with chlorhexidine, and MTA was placed over the exposed pulp tissue. The first shot of MTA was mixed with the blood. The second shot was thicker, and the third one was allowed to set. Glass ionomer was placed over the MTA to protect the MTA in composite resin restoration, all in a single appointment. You can see here in the video the pulp exposure. The depth of the diamond tip penetration was 2 mm inside the pulp tissue in order to remove the infected layers of the pulp tissue, and MTA was placed inside the pulp tissue. And this is the post-operative radiograph back in 2010. 3 years later, the 3-year follow-up radiograph revealed vital pulp tissue and dentinal bridging under the MTA, visible even in the periapical radiograph. The pulp tissue responded again within normal limits to thermal and electrical pulp testing. And this is the 4-year follow-up of this case. Still vital, asymptomatic, with no signs of calcific metamorphosis of the pulp tissue. And if you are wondering what kind of tissue is that is forming, human histology of the response to pulp tissue capping with biodentin and MTA reveals mineralized dentinal bridging with tubular dentin and a healthy odontoblast layer in contact with the regenerated tubular dentin, with a thicker dentinal bridging under the MTA. In a prospective clinical study of MTA partial pulpotomy in 28 teeth and a follow-up examination period of 12 to 26 months, 22 teeth, that's 79%, responded positively to vitality testing. The other 6 didn't respond, however, no complaints of pain or tenderness to percussion were noticed. A hard tissue bridging was observed in 18 teeth, that's 64% of the cases. Moreover, in this recent systematic review, vital pulp therapy presented a success rate between 72.9 and 99.4% up to more than 3 years. Partial pulpotomy sustained a high success rate of 97.5% or 94.9% for full pulpotomy. Even older studies evaluating partial pulpotomy success rates from 78 to 96 report high success rate, 96, 100%, 92%, 94, 100%, 86.5% success rate of partial pulpotomy treatment approach. Recently, the depth and activity of carious lesion has been used as indicators for the regenerative potential of the dental pulp after intervention. An active progressive carious lesion of the mandibular third molar, like in the first image, would demonstrate a light yellow appearance at the demineralized dentin and a corresponding more severe subodontoblasthic reaction in the pulp tissue. On the other hand, an arrested occlusion enamel lesion would demonstrate a clinical profile with a dark appearance with minimal, if any, subodontoblastic reaction near the arrested carious lesions. According to this article, there may be a difference in the regenerative potential of dental pulp relative to active and slowly progressing caries. The darker and more dry the carious lesion, the more active the regenerative potential of the underlying pulp tissue, exciting new research trying to identify specific proteome markers in carious dentin that will dictate the regeneration potential of the underlying pulp, so that we can always predict the response of the vital pulp tissue to treatment procedures. Until then, most of my cases with deep carious lesion and pulp exposure are treated with partial pulpotomy, like this case or this case in 11-year-old girl. And if you are trying to follow all the minimal invasive treatment approaches in dentistry, you have to know that in my humble opinion, preservation of the pulp vitality is for me the ultimate minimal invasive procedure you can get in endodontics. But besides dental caries, traumatic dental injuries may be also threatening the integrity of the vital, functioning pulp tissue of the permanent developing teeth. Traumatic injuries in children and adolescents are a common problem, especially for kids at 7 to 12 years old. However, not all the types of dental trauma will result in pulp involvement or necrosis. Pulp necrosis, as you can see in this graph, is the most frequent complication in avulsion injuries and intrusive luxation injuries. Intrusive luxation injuries, just like little Marlena's case, that was presented to my practice with an dentin enamel fracture in her right maxillary central incisor and an intrusion injury in her left one. The only thing I could do back then, in 2008, was to try and protect the exposed dentinal tubules of little Marlena's right maxillary central incisor with some bonding and composite resin restoration, and to leave the other incisor for spontaneous repositioning. Little Marlena missed all the scheduled appointments. She disappeared from my practice, but luckily for her, she returned 1 year later, in 2009. Although spontaneous repositioning was successful, both teeth became now necrotic and developed to sinus tracts. Moreover, if you notice carefully the radiography in the middle, you can see that a lateral wall defect is detectable in the periapical radiograph associated with the distal dentinal wall of the left maxillary central incisor. For over 30 years, cases like this were approached with apexification procedures. The goal of apexification, as proposed by Kaiser and popularized by Frank, was to induce a hard tissue apical closure of the necrotic immature root by reducing contamination within the root canal system by instrumentation and long-term medication with calcium hydroxide. And although successful enough, apexification procedures presented inherent disadvantages. Disadvantages like long time span of the entire treatment, multiple visits with heavy demands on patient and carers, and inevitable clinical cost, and increased risk of tooth fracture by using calcium hydroxide as a long-term root canal dressing. Moreover, apexification most of the times condemned the immature teeth in the cessation of the continuous root development. With the introduction of MTA, apical barrier techniques became rapidly the standard of care. One-visit apexification procedures were developed and became rapidly very popular. The rationale of one-step apexification procedure was to establish an artificial biocompatible apical stop against which immediate root canal filling and restoration could be achieved. The adoption of one-visit apexification protocols with MTA offered many advantages. Offered the advantage of shortened treatment time, improved patient compliance, but most of all, the rapid placement of a bonded restoration for the fragile immature root. And although the technique lacked continuous root development, it was considered very predictable, and for many clinicians around the world, it still is the standard of care when treating the necrotic immature root. But while advances with MTA and bonded restoration go some way towards a better outcome, no apexification method can produce the outcome that apexogenesis can achieve. But what could be done better for the necrotic immature teeth? After all, it had been shown that regeneration and ingrowth of a healthy, viable tissue into previously infected root canals could not be expected. The apexogenesis of the necrotic immature apex tooth was believed to be impossible for many years. At least until 2001, when dental traumatology published this milestone case by Vaya and colleagues of an immature permanent tooth with apical periodontitis and sinus tract undergoing apexogenesis. The patient was 13 years old, a sinus tract was present in close proximity to the right mandibular first molar, but vitality testing was negative only for the second mandibular premolar, and a diagnosis of apical periodontitis with sinus tract was made. Upon assessing the tooth, bloody and purulent drainage was noticed and the tooth was left open. And this is the case by Vaya and colleagues. 1 week later, at the second visit, no exudate was noticed and the canal was irrigated with 5% sodium hypochlorite and 3% hydrogen peroxide. A bi-antibiotic mixture of metronidazole and ciprofloxacin was placed and changed every next visit. At the fifth visit, the existence of vital tissue was noticed approximately 5 mm apical to the canal orifice by visual inspection. At the sixth visit, a thin layer of calcium hydroxide was placed in contact with the soft tissue in the root canal and sealed with glass ionomer and composite. No MTA was used in this first case. 15 months later, a dentine breach was found and checked with an explorer, and a positive reaction to vitality testing was achieved. And this was just judged as a remarkable result that shaped the foundation of apexification treatment approaches. In 2004, another report by Batcher gave reproducible results. An 11-year-old boy presented with an immature mandibular premolar associated with a large radiolucency and a lingual sinus tract. By using a triple antibiotic paste for disinfection and bleeding induction through laceration of the apical tissue, the authors managed to induce continuous root development and a thin wall thickening of the necrotic immature root. This is how we started, and you can see the 18 months follow-up radiograph. Both these cases were referenced to every single lecture and regenerative publication around the world. But how innovative were those suggestions that suddenly shifted the course of endodontics towards a regenerative direction? This is a paper by Rule and Winter published in British Dental Journal in 1966. The paper is titled Root Growth and Apical Repair Subsequent to Pulpal Necrosis in Children. I would like to read some lines from this paper for you. The patient, a girl 11 years old and 11 months, attended on September of 62, complaining of a gum boil adjacent to lower right 4. On examination, the right lower 4 was found to be non-vital, discolored, and a sinus opened of the gingiva, buccal to this tooth. The root canal was painlessly opened without the use of local anesthetic, cleaned to the level of bleeding tissue and dressed with a polyantibiotic paste. Polyantibiotic paste back in 1962. And the canal was reopened 2 weeks later, irrigated with sterile water, dried, filled with the resorbable iodoform paste and sealed. A periapical radiograph 11th month later showed root formation to be continuing. 3 years later, complete closure of the root apex. And although the quality of the radiograph is not that great, you can all notice the striking resemblance of this case that was published in 1966 with both cases by Vaya and colleagues and Bunch and Trope. And this is the comparative images of radiographic images of both cases of Bunch and Trope in 2004 and 1966 by Rudd and Winter. And this wasn't the only report in the literature that a vital tissue can grow inside an empty root canal space. In 1971, Nika Rosby and Olaf Hordal, tissue formation in the root canal following pulp removal. Tissue formation in the root canal after total pulpectomy and partial root filling. Horsted and Osby, 1978. I wonder what happened all those years and why apexification became so popular for treating these cases while all these techniques stayed at the dark side of the moon. And although I could place here numerous papers from pioneers in regenerative and biological thinking, this is not the objective of my lecture. My objective here is to give you my clinical perspective in reshaping the way to approach the treatment of the young necrotic pulp in permanent developing teeth. The basic philosophy behind the old and new best available evidence that guided my clinical shift is included in this paragraph. Extrapolating from all the new and old information, it is hypothesized that disinfection of a necrotic, infected immature permanent tooth with apical periodontitis may render it to the same starting point as a necrotic, uninfected, avulsed, immature permanent tooth. And if disinfection is achieved adequately, then revascularization should be possible for the disinfected canals just as it is for the uninfected canals in the avulsed scenario. So back to little Marlena's case, that we have now to deal with two central maxillary incisors, necrotic, with two sinus tracts. What I did in little Marlena, I assessed both teeth, one at a time, rinsed with chlorhexidine, 2% induced bleeding, and placed MTA over the blood clot. Unfortunately, in the right maxillary incisor, vital tissue was felt at the apical third of the root, and I couldn't induce bleeding up to the cement-to-enamel junction. Or it was my first case, and I was a little bit afraid of inserting of a file outside of the apex and induce bleeding in little Marlena. So I decided to place MTA up to the level of the vital tissue over there and perform something like single-step apexification procedure with MTA. However, in the left one, in the left maxillary central incisor, upon assessing the wide canal, vital tissue was found in the middle third of the developing root. Insertion of a file through a small access elicited a painful reaction to little Marlena from the level of the midroot. Disinfection was achieved with 2% chlorhexidine rinsing up to the level of the vital tissue. Bleeding was induced from this level and MTA was placed over the blood clot at the site of my access cavity. 1 week later, both sinus tracts disappeared. And although back in 2009 everybody suggested the use of antibiotics, I always had some concerns with antibiotic paste. That's why I selected to use this single-step revascularization approach. What were my concerns associated with antibiotic mixtures? A possible bacterial resistance, allergic reaction, crown discoloration, stem cell toxicity, or possible alteration in dentin strength and resistant to fracture. Little Marlena missed all the scheduled appointments and returned 1 year later. 1 year later, the periapical radiograph revealed continuous root development and dentin wall thickening. Interestingly, the lateral wall defect seemed to be healed. However, no signs of pulp vitality were present. 2 years later, clinical radiographical image reveals normal tooth development but still no signs of vitality. 4.5 years later, this is the clinical image. Little Marlena grew up to become a fine young lady, and this is a closer look of her white and pink aesthetics. Actually, there is a slight discoloration spot resulting from MTA that it's barely detectable. In regenerative endodontic procedures, you can have a discoloration for 3 reasons. One reason is the use of minocycline in antibiotic mix, if you are using antibiotic mix. However, in Marlena's case, I used a single-step revascularization protocol without the use of any antibiotics. The other reason of discoloration is MTA. The bismuth oxide of MTA reacts with collagen and gives you a grayish appearance, a grayish discoloration. And the other reason for discoloration may be the reaction of the MTA with sodium hypochlorite remnants. If you mix MTA with sodium hypochlorite, you will get again a grayish discoloration. However, the discoloration in little Marlena's case were barely detectable and was well tolerated by the patients. And this is live, the clinical image of little Marlena teeth 4.5 years later after single-step revascularization procedure. No periodontal proper depth, no mobility, asymptomatic. And I placed this video here with the sound because it was the only way for me to describe the positive response of little Marlena to electric pulp testing. Nay in Greek means yes. I don't know how reliable this is, but in little Marlena's case, 4.5 years later, after single-step revascularization procedure, I had signs of regaining of pulp vitality. And this is the radiographic image. Continuous root development, dentine wall thickening of the left maxillary central incisor was evident, but also you can notice continuous root development and dentine wall thickening even in the right maxillary central incisor under the MTA. Moreover, you can notice clearly here that the lateral defect was a rupture of the dental structures that seemed 4.5 years later to be completely healed. And at that time, many revascularization attempts around the world started to fill the peer and non-peer review journals, and by reflecting back to my early regenerative cases, I would think that the secret to explain the mechanism of regenerative endo procedure maybe is hidden, like George T. Huang mentioned, in the apical papilla that can survive bacterial invasion. The survival papilla could be a great source of stem cells during regenerative procedures. This exactly was what Lovelace and colleagues demonstrated in their paper. They demonstrated that the evoked bleeding step or revascularization protocols results in the delivery of stem cells into root canal system, and that the level of their molecular markers were several hundred-fold greater than the levels observed in the systemic blood. The data presented in this paper verified not only the delivery of stem cell markers into the canal space, but also that these cells originate from local adjacent tissue and not from the systemic circulation. And the best substrate for stem cells to grow is EDTA-treated dentine. Decalcification of the dentine surface, removal of the smear layer, exposure of dentinal tubules and collagen fibrils, and release of growth factors from the dentine matrix are favorable parameters for cellular differentiation at the dentine interface. Which growth factors? All these: transforming growth factor beta, basic fibroblast growth factor, vascular endothelial growth factor, bone morphogenetic proteins, insulin-like growth factors, platelet-derived growth factors, and all these growth factors. And although irrigation with 17% EDTA always supported best supported cell survival protocols that included 2% chlorhexidine, lacked any viable cells. So I skipped from my protocol, from my irrigation protocol, I removed chlorhexidine and I changed this with sodium hypochlorite. So let's try now together and induce continuous root development and dentine wall thickening in little Marlena's case. Little Marlena is 8 years old and was referred with this clinical radiographical image. The dental history revealed that the little girl had suffered a dentine enamel fracture 6 months ago. Emergency treatment was provided by restoring the fractured dental structure with composite. Now a sinus tract was evident and the tooth was percussion painful. A diagnosis of symptomatic apical periodontitis was made, and what would be now your treatment approach here? The traditional way of treating such a case would be by disinfecting the white canal and placing calcium hydroxide until symptoms resolve. In a subsequent appointment, an MTA apical plug should be placed and composite resin restoration over that. However, having experienced a successful case of one single-step revascularization, like in Marlena's case, let's try together and make our shift in treatment approach towards a regenerative approach. After all, failure to successfully regenerate the necrotic immature root leaves you many treatment alternatives to deal with. After explaining to the parents the objectives and the drawbacks of current revascularization procedures, an informed consent was obtained. This is the buccal view of the case, and this is the palatal view. Isolation sometimes in 7, 8 and 9 years old kids can be really challenging, and this is how I achieved isolation in little Joanna's case. Upon entering the pulp chamber, this is what I've got. Hemorrhagic and purulent drainage from inside the huge white canal. After leaving the white canal to drain, disinfection was achieved here by using 6% sodium hypochlorite syringe irrigation with light pressure in order to avoid extrusion of the irrigant beyond the apex. Passive ultrasonic irrigation was used in order to improve the irrigation efficacy, and sodium hypochlorite irrigation was followed by 70% EDTA syringe irrigation. EDTA was left inside the white canal for 4 minutes to let some dentin-derived growth factors being exposed, and then it was rinsed away with abundant sterile water irrigation. The white canal was dried with paper points, and bleeding was induced by laceration of the periapical tissue with a number 30K file. After waiting 15 minutes, a blood clot was formed, and this is the famous blood clot, as visualized under the microscope. A thick MTA plug was placed over the blood clot at the level of the cemento-enamel junction and was left there to set. Temporalization was achieved here with glass ionomer cement. This is the image under the microscope of the MTA coronal barrier, and this is the postoperative radiograph. 15 days later, the sinus tract was still present and a slight discoloration was making little Marlena's life miserable. However, the tooth now was asymptomatic and a decision was made to perform the permanent composite restoration and monitor the case. The temporary restoration was removed and the setting of MTA was checked. The black line around the MTA that you can see under the microscope, it's not leakage, it's staining. Yes, the white MTA stains the tooth structure. Bismuth oxide reacts with collagen and gives you a grayish discoloration. In the case of Joanna, staining was removed with the diamond burr. Actually, it was drilled out, and a composite resin restoration was achieved. This is the MTA. Composite resin restoration, the buccal view of the case, postoperative radiograph, periapical lesion here, tissue ingrowth for revascularization to occur, MTA barrier and composite resin restoration. 50 days later, 2 weeks later, the sinus tract was resolved and the discoloration was minimal and well accepted by the little girl. And the 1-year follow-up revealed healthy, soft tissue, while the radiographical image revealed dentinal wall thickening and maybe some continuous root development. Although continuous root development is not that evident, dentin wall thickening is evident. This is the 1-year follow-up. 2 years later, clinical examination revealed healthy, soft tissue, no sinus tract present, no periodontal probing depths and barely detectable cervical discoloration. You can see at the cervical area of the left maxillary central incisor the grayish discoloration over there. And this is the comparative recolor radiograph of this case. This is how we started in the first radiograph. In July of 2011 it was the post-operative radiograph, and 2 years later, although no vitality signs could be detected, it seems like the canal is getting more and more constricted and a dentinal breaching is evident under the MTA. Amazing regenerative potential of the young patient. Dentin wall thickening and dentinal breaching under the MTA. And this is the 3 years follow-up of little Ioanna's case. Radiographic clinical image. Continuous root development and dentin wall thickening is evident 3 years afterwards. If you search in the literature for articles evaluating single-step regenerative procedures like my previous cases, you will find only 1 case published by Sin in 2009 and very recently another one published by McCabe and these are the only single-step regenerative endodontic cases reported in the literature. But with me having experienced 2 more successful cases of single-step regeneration, I thought I could apply always this technique to all my necrotic immature root cases. Like little Antonis case here, that was referred to my practice back in 2011. After suffering dentin enamel fracture without pulp involvement in October of 2011, and a composite resin restoration was placed over there. 6 months later, the tooth became necrotic and developed a periapical abscess. Little Antonis was 8 years old then. So, in little Antonis, I applied exactly the same single-step regeneration protocol that I used for Ioanna's case. This is how I achieved isolation. This is the lingual image under the microscope, and this is what I got upon assessing the wide immature root. Exactly like Ioanna's case, hemorrhagic and purulent drainage from the wide immature canal. Left the tooth to drain for approximately 10 minutes and then started irrigating with sodium hypochlorite 6%, then flood the canals with sodium hypochlorite, perform passive ultrasonic activation of the irrigant again, rinse with sterile water and flood the canal with EDTA. This is the passive ultrasonic activation of the irrigant, of the sodium hypochlorite that you can see in the video. After disinfection procedures, I always rinse with sterile water the white canal and then flood the canal with EDTA, let some dentin-derived growth factors being exposed, rinse with sterile water again, and induce bleeding. This is the image you get under the microscope after the application of EDTA and the drying of the white canal. Induce bleeding from the side of the apical papilla, drive some stem cells inside the white canal, wait for 15 minutes for the blood to clot. Again, this is the blood clot. Wait for 15 minutes for the blood to clot and place MTA over the blood clot. In order to place the MTA, you can use an amalgam carrier, a small amalgam carrier like an MTA carrier. You deliver the MTA in your access cavity and then with light pressure you try to adapt the MTA at the level of the CJ. You see that the first shot of MTA is mixed with the blood, the second shot will be thicker, and the third one will be able to give you an initial setting of the material. This is the clinical image, however in this case I overpressed a little bit the MTA. Temporary restoration, glass ionomer restoration. This is my postoperative radiograph of my efforts here in Antonis' case. This is the clinical view 15 days later. I'm assessing again, removing the glass ionomer, temporary restoration, and this is the image I got of the MTA. I'm checking the setting of the MTA. The MTA seems set, although it turned out to be black and discolored, and I perform the final composite restoration. This is the comparative radiographic image, preoperative and postoperative radiographs, and this is the follow-up evaluation of Antonis' case. 9 months later, periapical lesion seems to be healed, but even 15 months later, although the periapical lesion is completely healed, I cannot identify any signs of continuous root development and dentin wall thickening. But the tooth is asymptomatic and the periapical lesion is healed. So let me ask you now a question. Is this case success or is it a failure? To determine whether this case is success or a failure, we have to review what was the objective of my efforts over here. If the objective is to induce healing of the periapical tissue, stimulate bone regeneration and render the patient free from any signs or symptoms, then my case would be termed as a success. However, if my objective was to regenerate a pulp tissue at integrum, this treatment would be deemed as failure. So maybe I have a clinical success but a biological failure. But you know, in cases like this, it's very important the long-term observation of the cases, not to stop there. So at least in my practice I try to follow my patient as long as possible. And this is the 21 months follow-up of Antonis case. You still believe this is a clinical success? Still the tooth is asymptomatic without any signs of infection. However, I can detect that something is going on at the apex of the immature root. And this is the 30 months recall of Antonis case. It's not only a biological failure, but it's also a clinical failure. On the basis of histopariologic observation, failure of revascularized, revitalized teeth could be due to inadequate root canal disinfection. So failure to eliminate the biofilm, especially with the non-instrumentation techniques that I used, may result in failure to induce continuous root development and dentin wall thickening. So maybe my technique in my single step revascularization technique wasn't good enough for all cases. Well-organized biofilms and long-standing infections could be resistant to irrigants used, and maybe after all antibiotic mixtures were needed in long-lasting infections. So in Antonis' case, I tried to retreat my failed revascularization case. And this is what I've got. I'm reassessing, this is a retreatment of a failed revascularization case. I'm reassessing the white canal, locate the MTA and try to remove the MTA with ultrasonics under continuous saline irrigation. And I have to tell you that the whole procedure wasn't as easy as I expected it to be. After removing the MTA, this is what I've got. Again, purulent drainage from the white canal, hemorrhagic and purulent drainage, together with discolored MTA remnants. I'm trying in this case to apply negative pressure irrigation in order to disinfect the white canal safely without risking extrusion of sodium hypochlorite beyond the apex. And although I tried hard, although I tried really hard to remove all the MTA remnants from the dentinal walls, I couldn't do it. I wasn't able to clean all the dentinal walls from the MTA remnants. And after disinfection with negative pressure irrigation with sodium hypochlorite, I placed a double antibiotic mix, in this case and this is my post-operative radiograph. The antibiotic mix in this case contained ciprofloxacin, equal parts of ciprofloxacin and metronidazole. I keep equal parts of ciprofloxacin and metronidazole in the fridge mixed together in a powder consistency, and just before clinical use I mix them with sterile water and use them as interim dressing. That's what I used here, and at the end this case got an MTA plaque after disinfection. Since I couldn't remove the MTA remnants from the dentinal walls, I thought I couldn't try again revascularization techniques. And after disinfection, this is the situation last November. In 2010, this paper was published suggesting improved disinfection by implicating negative pressure irrigation concept in the necrotic immature roots. According to Nestor Kohenka group, negative pressure irrigation in dogs provided similar bacterial reduction to that of positive pressure irrigation plus triple antibiotic dressing. So they suggested that the use of antibiotic dressing when negative pressure irrigation was applied may not be necessary. So I implicated in my disinfection approach negative pressure irrigation techniques with sodium hypochlorite. After all, 30 minutes of sodium hypochlorite negative pressure irrigation may be able to dissolve all the biofilm even without instrumentation of the wide canals like Ronald Ordinola Zapata suggested. And we may be able to reduce the biofilm thickness to a great extent, even without using high concentration of sodium hypochlorite, but by using 1% concentration of sodium hypochlorite. So in this next case, I applied again my single-step regenerative approach by applying negative pressure irrigation techniques. The little boy here had suffered the third impact injury in his anterior maxilla, and the right incisor had become now extremely mobile. And if you notice closely the radiograph, a fracture line at the apical third is evident, associated with a periapical lesion. When cases like this are referred, I always need time to think what I can do, and I always cannot help myself thinking regenerative endodontics again. Of course, this is an end stage case, but instead of extracting little Vasilis maxillary central incisor, maybe we can apply revascularization procedures and try to achieve hard tissue consolidation of the fractured immature apex here. Because imagine the detrimental consequences of extracting a 9-year, the central maxillary incisor in a 9-year-old boy. So, this is what I tried. The immature tooth is palpation and percussion sensitive, and this is the clinical situation. It's highly mobile, grade 3 mobility. This is the preoperative radiographical image of the anterior maxillary teeth. And this is how I achieved isolation. Upon entering the pulp chamber, again purulent drainage was noticed. The access cavity in the immature root was refined with long-shafted burrs, and the wide canal was irrigated first with positive sterile water irrigation. This is a closer look. Liquid dam was applied in order to enhance the isolation, and this is sterile water positive syringe irrigation in order to mechanically clean the white canal without risking extrusion of irrigant. After cleaning the white canal with sterile water irrigation, a number 100 headstone file was placed and a radiograph was taken in order to assess the depth of the apical fractures. The length was transferred to the macrocannula of the endovac, and apical negative pressure irrigation of 6% sodium hypochlorite was used for the disinfection of the immature root, followed by 70% irrigation of 17% EDTA irrigation to let some dentin-derived growth factors being exposed. After drying the canals, bleeding was reduced with a file mounted in a file holder, and you can see the bleeding from the white canal, and biodentin was placed and mixed with the blood. The first shot of biodentin here was placed again with the amalgam carrier used as biodentin carrier. This is the first shot of biodentin. You see that it's inevitable to be mixed with the blood. The second shot will be thicker, the third shot will stay there. You can wait for 15 minutes, 12 to 15 minutes for biodentin to set. However, in this case, I placed a temporary restoration and rescheduled little Vasilis. And this was my postoperative radiogram. I find very useful to use these these brushes for the appropriate adaptation of MTA or biodentin, of any kind of cement you are using in regenerative endodontic procedure, a dry cotton pellet inside over the biodentin, and temporary restoration. 10 days later the tooth was asymptomatic, and the biodentin was checked for proper settings. I'm tapping the biodentine. Biodentine is set as a rock and I perform the final composite restoration. This is my postoperative radiograph of my efforts, and this is 7 months later. The periapical lesion is almost healed, and it seems that the apical cracked immature apex demonstrates some signs of continuous root development. And this is the 8 months follow-up. This is the comparative radiographical image and the comparative clinical image. And this is the 22 months follow-up, almost 2 years. No signs of mobility, no signs of infection. The tooth is asymptomatic, and in the radiograph you can see some signs of continuous root development. Vasilis is happy because he still has his central maxillary incisor. I'm not suggesting that this tooth will stay there for Vasily for his whole life. However, my objective here is first to retain this tooth until little Vasilis becomes a grown-up and can predictably place an implant over there if needed. Sometimes cases like this are referred to my practice. I mean, what can you do in a case like this? Little Nafsika, she's 7 years old. She suffered an avulsion injury of her left mandibular central incisor. The tooth was replanted immediately and splinted in place. 6 months later, this is the situation. Almost the whole root is resorbed, external inflammatory resorption. When you see a case like this, the first thing that comes to your mind is that this teeth needs to be extracted. But as I told you before, in end-stage cases like this, I always take preoperative radiographs, preoperative clinical photographs, and take my time and think what I can do for little Nafsika. And in cases like this, I always can help myself thinking regenerative again. So, I would like to share with you what I did in little Nafsika's case. This was the situation when Nafsika first referred to my practice. If you remove the splint now, the tooth is highly mobile. I'm trying to assess little Nafsika's wide canal, and this is what I've got. Blood draining from the wide canal. This was the first appointment, and little Nafsika was not that cooperative. She flipped out, so I had to close some calcium hydroxide inside and a cavity and reschedule. In the next appointment, 1 week later, little Nafsika was more cooperative, and now I could perform exactly the same techniques with negative pressure irrigation with sodium hypochlorite. You can see again the knots in the macro cannula of the endovac, and I'm injecting sodium hypochlorite in my access cavity, and sodium hypochlorite gets evacuated from the canal. I'm inserting a number 80 file just to assess the depth of the external inflammatory resorption level, the level of the external inflammatory resorption, and I transfer this depth to the macro cannula on the endovac, exactly the same technique as little Vasilis. And after spending about half an hour with negative pressure irrigation, I flooded the canal with EDTA, wait for 4 minutes and induce bleeding, and place MTA over the blood clot. In order to minimize the discoloration effect of MTA in this case, because I didn't use biodentin in this case, I used MTA Angulus white. In order to minimize the discoloration effect, I placed some thermoplasticized gutta percha over the MTA and sandblasted my access cavity with sodium bicarbonate. This is the thermoplasticized GP barrier before sandblasting, and after sandblasting my whole access cavity is completely clean of MTA remnants that can induce discoloration of Nafsika's mandibular central incisor. This is the image after sandblasting. This is the radiographic image of my effort, and in the same appointment some composite resin restoration. This is all that I did in little Nafsika's case. Cleaned the white canal with negative pressure irrigation with sodium hypochlorite and induced bleeding and placed MTA. And this is almost 3 months later. This was the situation, and this is 8 months later, the clinical image, the lingual clinical image, and the labial view. The tooth is not, the mobility of the tooth is within normal limits.
Thank you.
And I left the sound here for you to see that the tooth is not ankylosed. The sound is almost the same with the adjacent teeth. And this is the radiographic image 8 months afterwards. And the comparative image, how we started and 8 months afterwards. And this is the 16 months follow-up radiograph compared with the initial situation. Healing is evident, no signs of ankylosis, mobility within normal limits, no probing depths. Little Nafsika is happy, we are happy, and Nafsika send you all a big smile and a big hug from Greece, and she's thanking you all for thinking regenerative and tried to save her tooth. And if you ask me what was that I had in my cases, was it dental pulp regeneration, revascularization, or repair? I would like to call it as blood clot healing after disinfection. Recently, America's Association of Endodontists, Colleagues for Excellence, published a recommendation about regenerative endodontic procedures, a guideline about the follow-up evaluation based on the common features of cases with successful outcomes, like the cases that I shared with you. According to the American Association of Endodontics, 2 or more appointments are needed, and the use of antimicrobial dressing, calcium hydroxide or antibiotic mix. They are not suggesting single-step revascularization procedures like my cases. Maybe in the future they will change their recommendation, but this is how it is right now. As far as irrigation techniques concerns, they suggest copious gentle irrigation with 20 ml of sodium hypochlorite with negative pressure irrigation in order to avoid extrusion of the irrigant beyond the apex, and they suggest lower concentration of sodium hypochlorite, 1.5%, 20 ml per canal for 5 minutes, and then irrigated with saline 20 ml per canal for 5 minutes, with the irrigating needle position about 1 millimeter short from the root end to minimize cytotoxicity of stem cells in the apical tissue. For interim dressing, they suggest calcium hydroxide or low concentration of triple antibiotic paste, and if triple antibiotic paste is used, consider always to seal the pulp chamber with a dentine botic agent in order to minimize the discoloration effect of the minocyclic component of the triple antibiotic paste. At the second appointment, 1 to 4 weeks after the first visit, anesthesia should be administered with 3% mepivacaine without vasoconstrictor in order to be able to induce bleeding. Copious gentle irrigation with 20 ml of 70% EDTA for dentin conditioning, and let some dentin-derived growth factors being exposed. Then dry the canal, the wide canal, with paper points, induce bleeding, and place a resorbable matrix over the blood clot such as cola plaque, cola coat, and cola tape. And then a 3 to 4 millimeter layer of glass ionomer to protect the MTA. And then monitor the case. What you would like to see in your follow-up appointments, it's no pain, of course, soft tissue, no soft tissue swelling or sinus tract. You would like to have resolution of apical radiolucency, and normally this is observed 6 to 12 months after treatment, and you would like to have an increased width of root canal walls and increase root length. And according to the American Association of Endodontics, the degree of success of regenerative endodontic procedures is largely dependent by the extent to which it is possible to attain primary, secondary, and tertiary goals. Your primary goal is always the elimination of symptoms and the evidence of bony healing. The secondary goal is the increased root wall thickening and increased root length, and your tertiary goal is the positive response to vitality testing. These were the recommendations of American Association of Endodontists. You can find this free of charge in the website of the American Association of Endodontics. It's free for everybody. However, if you would like, if I could share with you my opinion about my current clinical procedure during regenerative endodontic approach, I would like to share with you my disinfection protocol, my single-step irrigation protocol with this case, Christos case, 10 years old, asymptomatic with an immature root, negative pressure. Nowadays I'm using always negative pressure irrigation with sodium hypochlorite by using the sterile microsurgical tip by Coltin Weldon. This is length determination radiograph in order to transfer the length to your macro cannula. I am using 3% sodium hypochlorite negative pressure irrigation for 30 minutes, then rinse with sterile water under negative pressure irrigation and get rid of sodium hypochlorite, then flood the whole canal with EDTA, leave it there to expose some dentin-derived growth factors, sterile water again, negative pressure irrigation for 5 minutes to get rid of the EDTA remnants, dry the canals, and this is bleeding reduction with a file. And if your patient is anesthetized with mepivastacine, although anesthetized during the phase of bleeding reduction, he can feel something. Wait for the blood to clot, 15 minutes for the blood to clot, and when it comes to the maxillary anterior area, the aesthetic zone, I'm not using any more MTA material, I'm using either biodentin cement or bioceramic materials like putty in order to avoid the grayish discoloration resulting from the application of MTA in the cervical area, in the maxillary anterior aesthetic zone. This is my post-operative radiograph, how it looks like, and if you do all this as close as 2 weeks, you will have normally complete resolution of sinus tract, and the tooth now is asymptomatic. I'm still monitoring this case, and maybe in another lecture I will be able to share with you the long-term follow-up of this case. I would like to thank you all for watching my webinar, and most of all I would like to have your feedback of concerning regenerative endodontic procedures in the everyday clinical practice. A big thank to all people organizing this amazing event, and I hope I am able now to answer some questions, or maybe a lot of questions that you may have. Thank you. Thank you. This was Antonis Chaniotis for Endomasters 2015. Thank you all. God bless you.